Welcome back to AllAboutRx. Today, we're simplifying the anatomy of the thoracic cavity in this quick explainer. From the skeletal framework to the respiratory passages, we'll cover exactly what you need to know for your exams. So let's jump right into this high-yield, outside-in journey and get you fully prepped.
To keep things super efficient, here's our roadmap. We're hitting the thoracic cage, the thoracic vertebrae, ribs and sternum, the trachea and bronchi, lungs and diaphragm, and finally, wrapping up with the pharynx and larynx.
Starting off with Part 1, the thoracic cage and its bony framework. Let's establish the boundaries of the thorax. It's that vital region sandwiched right between your neck and abdomen. This protective cage is basically built from 4 key components working flawlessly together to shield your heart and lungs, all while actively helping you breathe. You've got the 12 thoracic vertebrae anchoring the back, 12 pairs of ribs sweeping around the sides, the sternum locking it all down in the front, and the flexible costocartilages connecting those ribs to the sternum. The superior thoracic aperture, or thoracic inlet, is bounded at the very top by the T1 vertebra, the first ribs, and the upper border of the sternum. Think of this inlet as a busy highway letting the trachea, esophagus, and major blood vessels pass right through. Down at the bottom, you have the much larger inferior thoracic aperture, which is completely sealed off by the muscular diaphragm. Moving on to Part 2, thoracic vertebrae, the posterior pillars of our cage.
If you need to quickly identify a typical thoracic vertebra, say T2 through T8, you're looking for that classic heart-shaped vertebral body. You'll also spot a circular vertebral foramen and a long, downward projecting spinous process. But the absolute dead giveaway? The superior, inferior, and transverse costal facets. These are specifically designed for rib articulation.
Now, what's really high yield here are the structural exceptions. T1, T9, and T10 through T12 totally break the typical rules, which is exactly why examiners love them. T1 features a complete facet for the first rib. T9 might lack an inferior facet altogether. And T10 through T12 keep it simple with only a single costal facet each. Keep those variations in your back pocket for sure.
Next up, Part 3, the ribs and sternum, acting as our anterior shield.
Ribs are strictly classified by their anterior attachment. So, true ribs, that's 1 through 7, earn their name by attaching directly to the sternum. False ribs, which are 8 through 10, attach indirectly by piggybacking onto the costal cartilage of the 7th rib. And then you have the floating ribs, 11 and 12. They have absolutely no anterior attachment at all, and just end right in the abdominal musculature.
A crucial anatomic feature for any single rib is the costal groove, which runs along its internal, inferior surface. This groove is essentially a protective channel for the highly vulnerable intercostal vein, artery, and nerve. You can easily remember them in top-to-bottom order with the acronym VAN. This is incredibly important to know because if a patient suffers a rib fracture, those vital vessels running right there in the groove can easily get severed.
Looking at the sternum, you absolutely have to know the sternal angle, or the angle of Louis. Sitting right at the T4-T5 vertebral level, it's a massive surface guide. It marks the exact site of the second rib articulation, and if you look deep inside the chest at that same level, it tells you exactly where the trachea splits into the bronchi.
Why does this actually matter in the real world? Well, these bony landmarks guide everyday medical procedures. You use that sternal angle to find the second rib, which is your starting point for counting ribs during a physical. The body of the sternum is a super accessible site for bone marrow aspiration. And the lower sternum, that's your literal life-saving landmark for proper hand placement during CPR chest compressions.
Let's transition to Part 4, the trachea and bronchi, forming the lower respiratory tract. Tracking the air we breathe reveals a very specific order you need to memorize. Air travels down the trachea, splits into the primary bronchi, divides into secondary lobar bronchi, then tertiary segmental bronchi, and finally the terminal bronchioles. From there, we hit the respiratory zone. Respiratory bronchioles, alveolar ducts, alveolar sacs, and the alveoli. This entire end stage, where the magic of gas exchange actually happens, is collectively known as the acinus. Zooming in on the trachea, it extends roughly 10 to 12 centimeters down, from C6 to that T4/T5 sternal angle we just talked about. And right at that bifurcation point, it hits the carina. This is a highly sensitive cartilaginous ridge. If a foreign body, even a tiny drop of liquid, touches this ridge, it triggers a violent cough reflex to protect your airway instantly. Once the airway splits at the carina, pay close attention to the structural differences between the right and left main bronchi. The right bronchus is wider, shorter, and runs in a much more vertical direction. The left bronchus, on the other hand, has to make room for the heart, so it's narrower, longer, and travels a lot more horizontally.
This structural quirk perfectly explains a classic exam question and a super common clinical scenario. If a patient aspirates a foreign object, like a swallowed tooth or a piece of food, it is statistically way more likely to end up in the right lung. Gravity, combined with the wide vertical path of that right bronchus, basically acts like a funnel straight down into the lung.
Moving on to Part 5, lungs and diaphragm, the vital engines of the thorax.
Because of where the heart sits, our lungs are actually quite asymmetrical. The larger right lung features 3 distinct lobes, superior, middle, and inferior, which are separated by 2 fissures, the horizontal and the oblique. The left lung, however, only has 2 lobes and a single oblique fissure to make room for the heart via that prominent cardiac notch. And right below that notch on the left side is the lingula, which is the small tongue-shaped projection off the superior lobe.
Sealing off the floor of this entire cavity is the diaphragm, our main muscle of respiration. When it contracts, it flattens out, massively increasing the volume in the thorax and pulling air into the lungs. You must never forget the classic mnemonic for its phrenic nerve supply. C3-4-5 keeps the diaphragm alive. Damage to those cervical nerve roots means severe respiratory compromise.
Finally, Part 6, the pharynx and larynx, our upper connections.
The larynx acts as both an air passage and your voice box, and it relies on a highly specific set of cartilages to protect the airway during swallowing and to help you produce sound. It's elegantly divided into 3 unpaired structures: the large thyroid, the ring-like cricoid, and the leaf-shaped epiglottis. These work right alongside 3 smaller paired structures, the arytenoid, corniculate, and cuneiform cartilages.
Before you go, let's do a quick recall of the absolute must-know facts. The superior aperture equals the thoracic inlet. The sternal angle sits right at the T4/T5 level and marks your second rib. The right bronchus is the classic site for foreign body aspiration, and the larynx is located at C3 to C6, while the diaphragm is supplied by C3, C4, and C5.
We've built the bony structure, traced the airways, and covered the vital organs inside. But how does it all fail under pressure? If the thoracic cavity is a perfectly sealed system that relies on negative pressure created by the diaphragm, how exactly does a condition like a pneumothorax disrupt this delicate balance and cause a lung to collapse? Think about the physics of that sealed space as you review your notes. That's it for the thoracic cavity. Don't forget to like and subscribe to AllAboutRx for more high-yield anatomy notes. See you next time.